It's an honor for me to present this symposium that the name is Strengthening the Geriatric Workforce for Implementing Care for Healthy Aging. The first speaker will be Anshu BANERJEE, Director of Maternal and Newborn Child and Adolescent Health and Aging of World Health Organization of Geneva, Switzerland. He will speak about the young decade of healthy aging, scaling up integrated health and long-term care for older persons.
Thank you very much, and it is a pleasure to be here together with you. Populations around the world are aging at a faster pace than in the past, and this demographic transition will have an impact on almost all aspects of society. Already, there are more than 1 billion people aged 60 years or older, with most living in low and middle income countries. In recent years, the world has been confronted with multiple global challenges: pandemics, climate change, war and inequality. As a result, countries are falling behind on their sustainable development goals, which ultimately impacts health and well-being of older persons, their families, and communities in which they live. To address this for older people, the UN announced the United Nations Decade of Healthy Aging, which is a global collaboration aligned with the last 10 years of the Sustainable Development Goals that brings together governments, civil society, international agencies, professionals, academia, the media, and the private sector to improve the lives of older people, their families, and the communities in which they live. Its vision is a world in which all people can live long and healthy lives. This new global action plan, the Decade of Healthy Aging, was endorsed by 194 countries at the 73rd World Health Assembly on the 3rd of August 2020, and subsequently it was also welcomed by the UN General Assembly on 14 December 2020, leading to the proclamation of the UN Decade of Healthy Aging. Initiatives undertaken as part of the decade will seek the participation of older people who will be central to and fully engaged in this multi-stakeholder collaboration. WHO will act as the lead in close collaboration with other UN agencies such as the United Nations Department of Economic and Social Affairs and its regional commissions, the United Nations Development Fund or UNPF, the Office of the High Commissioner for Human Rights, the United Nations Development Programme, UN Habitat, UN Women, the World Bank, and other relevant national, international, and regional organizations. The decade brings together a variety of stakeholders galvanizing concerted action to change how we think, feel, and act towards age and aging, develop communities in ways that foster the abilities of older people, deliver person-centered integrated care and primary health services that are responsive to older people, and to provide older people access to long-term care when they need it. The decade also recognizes the importance of 4 enablers. Strengthening the geriatric workforce in all countries is crucial for action areas 3 and 4. In relation to the enabler on data, strengthening data on the available geriatric health workforce for organizing integrated health and long-term care services is very important. Action Area 1 also highlights the need for tackling ageism in the healthcare industry. For example, older health and social care professionals face age-based discrimination that can limit their employability. In the coming years, every country must find solutions to sustain the employability of aging health and social care professionals and build an organizational culture that prevents age-based discrimination in health and long-term care systems. Healthy aging is not about the presence or absence of diseases. It is about improving older persons' intrinsic capacities and functional abilities, which are critical for optimizing healthy aging across the life course. The continuum of care and integration of services are the two primary goals for transforming the current disease-oriented healthcare systems to one that addresses the needs of older people. The WHO Integrated Care for Older People approach is designed to promote integrated and coordinated provision of a broad spectrum of services, such as management of chronic geriatric conditions, rehabilitation, palliation, promotion, and preventative services. The evolution of a system to promote healthy aging cannot occur without effective integration of health and social services within long-term care. Long-term care has been defined as activities that ensure that people with or at risk of significant ongoing loss of intrinsic capacity can maintain a level of functional ability consistent with their basic rights, fundamental freedoms, and human dignity. Long-term care is an essential component of integrated care, providing adaptations consistent with the dynamics of the individual's intrinsic capacity and functional ability over the life course. In order to support countries to implement care for older people, WHO launched the evidence-based integrated care guideline for organizing community-level interventions to manage declines in intrinsic capacity. Subsequently, WHO developed implementation frameworks to support countries in reorienting systems and services for organizing integrated health and long-term care services. Recently, WHO leveraged digital technology and developed the iCope app to support primary care professionals in conducting comprehensive health assessment and to develop a care plan. Why is strengthened health and care workforce a prerequisite for implementing the UN Decade? Older adults account for a quarter of all outpatient visits and hospital stays in many countries, and this percentage will likely increase as demographics and health change. In the current clinical training curriculum, care needs of older persons are often underemphasized. As a result, health professionals are inadequately trained in core geriatric competencies. These include comprehensive assessment of older persons, managing multiple impaired older persons with significant loss of intrinsic capacities, and management of common geriatric syndromes such as dementia, delirium, falls, and incontinence. It is not only training, but also numbers. There is a need for additional licensed practical nurses, home health and personnel care aides, and certified nursing assistants. Sustainable Development Goal 3 aims to ensure healthy lives and promote well-being for all at all ages. One of its core targets is to achieve universal health coverage. Universal health coverage means ensuring that all people and communities receive the quality services they need and are protected from health threats without financial hardship. Shortage of health professionals with geriatric competencies affect the quality of services organized for older persons at the health and long-term care settings. New strategies for strengthening health workforce for geriatric care are therefore urgently needed. These may include education of all providers who will encounter older persons at all levels of health, primary, secondary, and tertiary levels, and long-term care systems, and also developing new knowledge through research that can inform and enhance the effectiveness of care for optimizing healthy aging. By endorsing the UN Decade of Healthy Aging, countries have made a commitment to scale health and long-term care systems, which includes strengthening health workforce. However, monitoring available and estimating required human resources for organizing care for aging is also very challenging. Several important geriatric workforce cadres, such as geriatricians, geriatric nurses, geriatric social workers, gerontologists, are not classified as health occupations. Lack of standard definition and data are two main reasons for this invisibility. In collaboration with the IAGG, WHO is developing and refining geriatric work cadre definitions and to facilitate the implementation of these definitions in the official list of health occupations. Using these definitions, WHO plans to collect data to estimate growing demand and supply of geriatric workforce in countries. Thank you very much for your attention.
The next speaker is Dr. Jack Rowe. He is former president of the International Association of Gerontology and Geriatrics. He is professor of health policy and aging of Columbia University in Mayman School of Public Health in the United States of America at Columbia University. He will speak about the World Health Organization and AGG joint initiative, defining the geriatric workforce.
Hello, I'm Jack Rowe, president of IAGG, and I want to review with you the IAGG World Health Organization project on the definition of a geriatrician. Next slide, please. Late last year, the World Health Organization asked IAGG to develop a definition of a geriatrician, which the WHO could use in conjunction with their very ambitious A Decade of Healthy Aging program. We assembled a group of 14 expert geriatricians who are listed here. And you can see that they are from South America, Asia, Africa, Europe, Sub-Saharan Africa, as well as Mediterranean Africa. And we developed a definition of a geriatrician, and then went a bit further and developed some information about guidance regarding the practice of geriatric medicine. The World Health Organization accepted our definition and has deployed it to its work. And I'd like to review the results of this effort with you. Next slide, please. So our definition said that geriatricians are physicians who devote their efforts to the prevention, the diagnosis, the management, and the rehabilitation of diseases and clinical syndromes common in older persons, such as frailty and delirium. Geriatricians are generally board-certified physicians, most often in internal medicine and in some countries in family medicine, who take advanced training and gain certification in geriatric medicine. The composition and the duration of the training and the process for certification vary across countries, but we are emphasizing here the importance of geriatric syndromes, the importance of advanced training, and the importance of certification. Next slide. Other clinicians that are focused on care of older persons are identified with specialty-specific titles, such as a geriatric psychiatrist, a geriatric dentist, a geriatric social worker, geriatric nurse practitioner. This varies across countries. There is also no specific chronological age that qualifies patients for the care of a geriatrician, as advancing age is characterized by substantial variability between individuals in their onset of disease and disability. Next slide, please. When it comes to the practice of geriatric medicine, we offered the following key characteristics. First, there is a special focus on the preservation and the optimization of functional capacity. It is all about function. It's not about a list of diagnoses. Next is we feel a life course perspective is important. It recognizes the accrual of advantage and disadvantage over time based on lifestyle, exposures, and other factors. Geriatrics involves the management of patients with multiple morbidities, geriatric syndromes, and complex clinical presentations. Patient-centered geriatric care includes comprehensive multidisciplinary assessment of functional, medical, and social factors. Next slide. Additional characteristics include that clinical operations that usually involve an interdisciplinary team and assure comfort and dignity are characteristic of geriatric medicine. There is an emphasis on the clinical implications of the biology and the physiology of aging, and thus geriatricians must be deeply schooled in understanding the biology and physiology of aging. Geriatric care spans the spectrum from population-based education and prevention efforts to the management of acute illness and the long-term care of chronic conditions. And it involves provision of care in a variety of settings, ranging from the community to acute and long-term care facilities. Next slide. As I indicated at the outset, in addition to this work, IAGG is now working with WHO to develop working definitions of other clinicians involved in the care of older persons, including geriatric nurses, social workers, and others. And this will be organized by the team in Argentina in the new secretariat. Thank you very much.
The next one will be Dr. Matteo CESARI. He's consultant of Aging and Health Unit in the World Health Organization, Geneva, Switzerland, and he will speak of role of the geriatrics workforce implementing care for healthy aging.
Good morning. It is a pleasure and an honor to present these slides about the role of geriatric workforce in implementing care for healthy aging. As we well know, and it's been graphically shown in the cover of a report by the UK Royal College of Physicians a few years ago, our hospitals, our care systems are collapsing under the overwhelming number of complex older persons referring to them. The system is not ready for the quantity and quality of new patients that are daily referring to our services. The complexity of the new patients that we are managing on a daily basis is too high for allocating proper care and resources. Besides of the complexity of the older persons, there is also a problem in the workforce. This is just an example published a few days ago in The Guardian about the situation of the UK physicians, and in particular about the lack of geriatricians. I mean, there is a problem in finding persons specifically trained for taking care of older persons. In the UK, the report was showing one geriatrician every 8,000 older people. Also pointing at the fact that many of the consultant geriatricians are going to retire in the next few years. This is just an example because this situation is very common worldwide, and please consider also which is the situation in many countries where geriatricians are not formally identified in the cares and academic system, where the priorities might be potentially elsewhere, driven also by other clinical issues. We have seen this during the COVID-19 pandemic. There is indeed a request of geriatric care across the whole spectrum of services, care services. There are many specialists that today are looking at what geriatricians and the geriatric workforce has been doing over the past decades, because they simply do not know how to handle the complexity of the older persons, are trying suggestions, hints at tackling the frailty conditions, the geriatric syndromes, something that they are seeing for the first time. And I think during the COVID-19 pandemic, this has been really enhanced. At the same time, we also know that there is an ageistic approach in the society and in the care system that is, again, another barrier for which geriatric medicine has always been find difficulties at being proposed and routinely implemented. Now, in the next slides, I will show you how the geriatric workforce, to me, may play different roles at different levels, according and in respect of all the experience that has gained over the years. Because geriatricians and professionals working in geriatric medicine have been developing special expertise in dealing with the complexity of older persons, managing persons that were otherwise abandoned, neglected, left out from traditional care. We have developed instruments, methodologies, services to address specific needs, and I think this is the time for giving the right value to what has been doing, because there is an increasing demand about our services. Now, I think we may work at three different levels. The geriatric workforce may provide information, expertise on how to approach to the older person at the clinical level, may serve to reorienting services, and so at the meso level may take the role of coordinating the evolution of services for older persons, and then may play a role at the public health level, at the macro level, trying to inform the policymakers about some system modifications that are needed for adequately care the aging population. Now, starting from the first level, the clinical base, we know that the main methodology used by geriatricians is the comprehensive geriatric assessment. This is the definition of CGA provided by Ellis and colleagues in a cornerstone paper of geriatric medicine, where it is discussed, it is presented, the CGA as a process that is multidimensional and multidisciplinary. So geriatricians, the geriatric workforce, has traditionally been trained at working in a transversal way, without a real hierarchical positioning, but I mean every specialist, every professional at the same level of the other, because we need interactions with him. We need more than two eyes because of the complexity of the patient. The CGA is diagnostic and therapeutic, and in particular it is conducted to determine the medical, mental, and functional problems of older persons with frailty in a coordinated and integrated way. The goal of the CGA is to develop a personalized plan of intervention. Now, all these concepts that are nested in the nature of the geriatric medicine professionals is something that should be proposed to everyone else, given the robustness of this methodology in terms of benefits for the older persons. And for doing this, besides of the knowing the and implementing the technique, a geriatrician may have a role on training the others, the non-specialists, at this kind of methodology that has shown to be extremely successful. This is just an example provided by the experience of Professor Morley, in which he describes the rapid geriatric assessment, taking into account the need to increase knowledge in care providers, and at the same time the need of being implemented to fill the current gaps of knowledge in the management of older persons. Professor Morley has developed this methodology and simplified the CGA in order to cover the basic principles of geriatric medicine. In other words, he has tried to delegate some of the key aspects of geriatric medicine outside of the hospital, outside of the specialist world, go into the primary care, integrating information and training persons at something that might solve the basic issues of older persons. We have at the meso level, at the service level, experience in generating multidisciplinary units. Here, for example, the orthogeriatric unit, or the development of oncogeriatric units that are based on the fact that different actors may play a complementary role in the assessment and management of older persons with frailty. So the geriatric workforce has played a role in redesigning services, promoting multidisciplinarity in order to personalize care and providing to the person a person-tailored intervention that is designed according to his values, priorities, and needs. The implementation at the service level has also been of the geriatric knowledge and expertise has also been trying to connect the hospital world with the community, with the territory, with the primary care services. And for example, this is an article coming from the experience by Anshu and colleagues, who have been developing a model of care that is implementing the concept of frailty in primary care in the UK. So the geriatric concept of frailty is now seen by the care practitioner in order to implement in preventive and therapeutic interventions. And this is a similar example coming from the experience by Marco Inzitari and colleagues in Barcelona, where there has been this synergy generated between geriatricians, primary care physicians, physical therapists, and social workers. Now, all these concepts can also be found at the macro level, because they have been informing the recent development that have occurred at the WHO in terms of proposing a new vision of aging. In 2014, the World Report on Aging and Health has proposed a new framework of healthy aging that has been developed over the past few years, in which it is described the concept of intrinsic capacity, of functional ability, of environment. In other words, it has been described the need of approaching the older person in an holistic way, reorienting services and integrating services, especially connecting the hospital with the community for providing personalized interventions for older persons. And in this scenario, trying to let systems evolve according to the new needs of the aging population, we find very often terms, methodologies, concepts that are very familiar to us, to the geriatric workforce, but are not so clear and perhaps very often are very novel for non-geriatricians, for persons who are dealing for the first time with the complexity of older persons. In this recent paper published in BMJ Global Health, we talk about continuum of care, reorientation of services, pension-centered models of care, and coordination. So, in conclusion, the sustainability of the care systems is today challenged by this overwhelming number of older persons and their complexity. We need to reorient the services, taking advantage of our experience. And for this reason, the geriatric workforce may play a role for coordinating the evolution of the care system, also by training the future generations of professionals to the very basic principles of geriatric medicine in order to extend the network where we can identify in an early we can timely identify the problems, preventing the disability process and maintaining the persons at home where they want to live and age. Thank you.
The next speaker is Dr. AMUTHAVALLI Jotheeswar. He is Technical Office in Aging and Health Unity of World Health Organization in Geneva, Switzerland, and he will speak of challenge in monitoring and forecasting the geriatrics workforce.
Good morning, good afternoon, good evening, wherever you are in the world. For the next few minutes, I'm going to explain what is geriatric workforce from WHO perspective, and then provide a rationale for monitoring the geriatric workforce in the countries, and some of the challenges that we have in estimating the geriatric workforce, and then explain a little more about the WHO's approach towards mapping the available geriatric workforce in countries, and finally, way forward. What is geriatric workforce? There are various definitions used for geriatric workforce, but in the context of attaining sustainable development goals, it is important to have a broader and inclusive perspective of health workforce in countries. Therefore, geriatric workforce can be described as all persons engaged in care services whose primary intent is to enhance the health and well-being of older persons. This includes physicians, nurses, social workers, psychologists, gerontologists, physiotherapists, occupational therapists, pharmacists, dentists, community health workers, formal and informal caregivers, and others. Why WHO wants to monitor geriatric workforce? There are three main reasons for taking stock of geriatric workforce in countries. First, monitoring the geriatric workforce is crucial for tracking the progress towards universal health coverage and the UN Decade of Healthy Aging. Second, estimating demand and supply of geriatric workforce will enable countries to develop strategies that ensure equitable and effective distribution of available resources. Last, we want to forecast the future need of geriatric workforce in countries. This will enable countries to implement policies to strengthen the workforce that could address the growing demand of health and social care needs of older persons. Estimating geriatric workforce in the country is simple. For example, if you want to know how many geriatricians are available for organizing care for 100,000 older persons this year, we just need to count the number of geriatricians from training institutions entering the service, and the number of geriatricians who are currently in service, and the number of geriatricians who are going to retire this year. If we know where these people work, we can also have a distribution of geriatricians within a country. Though it sounds simple, it's not easy. There are many challenges in estimating and producing reliable estimates on available geriatric workforce in the country. These include definitions, data, and models. To make an accurate calculation of the stock and flow of geriatric workforce, a systemic and consistent definition for each workforce cadre are mandatory. Standard definitions enable data and information collected from different sources, for example, public and private sector, professional registries, labor force surveys, etc., to be comparable and used consistently in the model and estimation of available geriatric workforce. At present, standard definitions for many geriatric workforce cadres are unavailable. Second challenge in estimating available geriatric workforce is the lack of data. Data and number of active geriatric care professionals and their distribution in the health system are a key requirement for planning and implementation of program policies and services for older persons. Workforce information systems fail to deliver comprehensive, reliable, and timely data in many countries. For example, in some countries, the data on geriatric care workers and the trainees, their specialization, the geographical spread, age, gender, and country of province are not available, or not registered properly. Besides, there is also a lack of accurate data and migration of workforce in most countries. For estimating available geriatric workforce and forecasting future needs, WHO uses three models: supply-based models, demand-based models, and need-based models. Supply-based approach, which focuses on balancing geriatric workforce inflow and outflow and the active rates of currently active workers. Demand-based approach focuses on current and future demand for health and long-term care services, estimated from population composition, demography, and health service utilization. Need-based approach extends the demand-based approach by additionally considering epidemiological and sociocultural factors. For geriatric workforce, these models were not empirically validated, hence limiting our possibilities for assessment of quality and impact of various models on workforce and health system performance. To overcome some of the challenges I just highlighted, WHO will take following step. First, we will define the function and services the geriatric workforce are expected to deliver for healthy aging. Second, we will like to create a competency frameworks required to deliver those services. Third, using the competency framework, we will collect data on available professionals in each country with those competencies. And last, we will apply a suitable model and estimate the available resources. In moving forward, WHO will continue to work with IAGG and expand and develop definitions for all cadres of geriatric workforce based on the competency framework. And WHO will apply these definitions and pilot test the feasibility of collecting data in few countries. And in 2023, WHO will establish a data collection mechanism in consultation with the IAGG and other geriatric associations at the regional, national level, which will enable us to build a need-based forecast model for geriatric workforce. Members who wish to contribute to this workstream, please contact Professor Miguel, or you can directly contact me through my WHO email address provided on the slide. Thank you for listening.
Now we have the time for question and answer if you have any doubt or any suggestion to do. We have two questions in the auditory for the speakers. The first question is, across countries, training duration and certification process differ. In the definition of geriatrician, how can we incorporate this heterogeneity?
Miguel, would you repeat that question, please?
Okay, the first question is, across countries, training duration and certification process differ. In the definition of geriatrician, how can we incorporate this heterogeneity?
I guess I don't understand the question. In the definition of a geriatrician, how can we incorporate what?
The heterogeneity, because they say that they have no certification process the same in all the world. Several countries have different.
Yes. Okay. I'm sorry. Well, I think that we recognize that the approaches to certification vary dramatically in different regions and countries. And in some countries, for instance, I think Thailand, family practitioners can become geriatricians, but they can only work outpatient, whereas internists can work inpatient. There are different definitions of what they can do and where they can do it, and we respect those differences. We are not trying to develop a unified global definition. That would not be suitable for the very different stages of development of geriatrics in different countries. So I think what we are really talking about is maintaining some certification, some formal training, and a focus on geriatric syndromes, functional assessment, life course perspective. Those are the elements that we are looking for, and we are not looking to homogenize the definition or the training or the certification.
Anybody want to answer this question too?
Thank you, Miguel. And maybe just to add to what Jack has said, I think it's important that we first look at what are the competencies that the healthcare workers need to address, let's say, how to do a comprehensive assessment of an older person, but really looking at the older person holistically. And from that perspective, really looking at what are the competencies needed for this healthcare worker to ensure that the older person can maintain their intrinsic capacity and can also improve their functional ability. And once we have identified those competencies, then we can go to the next step and sort of identify what is the curriculum needed in order to train a healthcare worker to be able to address these conditions and be comfortable with those competencies. And then we can sort of look at, in different systems, in different contexts, how would this then be applied to the definition or the curricula for specific geriatric professionals, let's say, the different kind of geriatric healthcare professionals that provide these services.
I would also add that in some countries, rather than requiring formal curriculum, approaches have included a so-called practice pathway, where if somebody can document that they have in fact worked in geriatric medicine, perhaps in a long-term care setting for a substantial period of time, that they would be deemed to be eligible to become certified. But it still requires that they pass an examination to demonstrate their competence. That's a critical feature of what our definition includes. And in the United States, when we started a certification in geriatric medicine, we had the so-called practice pathway for 5 years. And so to give those people who had never been formally trained an opportunity to take the exam, but they have to demonstrate the competence.
Yes, if I can add, I agree with what has been said. I think it is also a matter of defining the geriatric pathways. I mean, we have the curriculum and the training for the person, but I mean, this expertise should then be contextualized in a reorientation of services for serving the increasing demand of geriatric practice. So I think it is an entire package that has been that has to be considered here. We can work on the training of the next generation or future generation of clinicians with specific expertise in geriatric medicine. We need to define the curriculum of the specialists in geriatric medicine, but we also have to provide this training in the context of geriatric settings that very often receive this label just because they have old persons admitted to them. But there is not really the geriatric expertise over there, the integration of services and the multidisciplinary exchanges that are needed as the background for geriatric medicine.
Okay, Jotheeswar, you want to answer the question?
Thank you, Miguel, for this wonderful question. I think from WHO side, we want to use this competency framework for mapping available human resource in the country, and then go forward. When we use this competency framework, we may be able to map out what proportion of physicians have those competencies. Maybe some of those physicians may be having a training in geriatric, have gone through a formal training, and we may be able to label them as geriatricians, but we definitely need this competency framework to start mapping the available human resource in the country. And the challenge is that in the definition, should we include those different competencies that geriatricians required, or the definition needs to be based on the education and the duration of the training? Should that be a focus in the definition, or the definition should also include competencies the geriatricians needed? Is another question that we have been having internally within ourselves.
Okay, I will make the other questions. The second question that we have is, besides geriatricians and other physicians like cardiologists or ophthalmologists have a role in caring for the elderly, are they considered geriatric workforce members?
I think the answer is yes. And I think we have to recognize that the number of geriatricians in most countries, as we saw data this morning from the United Kingdom, and it's certainly even worse maybe in the United States, one geriatrician for every 8,000 or so older persons. This is nowhere near what we need. And we need to be cast a wide net here, build a big tent. We need to include individuals, not only because of the inadequate number of geriatricians, but because these other people bring expertise, which is very critical toward the syndromes and the functional impairments that we've been talking about. And so we don't mean by establishing what some people would call a strict definition of a geriatrician to exclude all these other people from the geriatric workforce at all. We want to include them. We want to recognize their contributions. We want to encourage the development of more advanced practice nurses and geriatric social workers and dentists and others.
Okay, Anshu, do you want to answer this?
Yes, just to add to that, looking at the person holistically, we do recognize that these specializations and these specialists, let's say, contribute to specific areas, specific domains within the intrinsic capacity or functional ability. And so, for example, the ophthalmologist sight is very important, And in order to enable older people to maintain their vision, if their sight has gone has reduced, let's say, then the provision of spectacles will ensure that they are still functional, and so they have addressed the environment of the older person to ensure that they have compensated for the lack in intrinsic capacity by improving the environment, and therefore ensured that they are functionally able to contribute to society. So from that perspective, they are really contributing to the overall care for the older person.
Okay. Matteo, please.
Yes, I think we need to be careful on some aspects here. I mean, I have never thought of myself as a cardiologist because all my patients have an art. So the definition of the geriatric workforce implies a geriatric approach, an approach that is based on the basic principles of geriatric medicine. I think this question might be reversed, considering the person at the center of an action plan that is putting together all different actors that are sharing the same idea of integrating information, integrating services, sharing expertises, discussing about the priorities and needs of the individual in order to tailor the intervention. So I think everyone who is able to share this common framework will be very welcome in the geriatric workforce.
Okay, Jotheeswar, please.
Thank you, Miguel. I think this is an important question that we have been struggling, because if we use the strict geriatrician definition, we may be underestimating the human resource available in the country, who may not be providing exactly the care the geriatrician could provide, but at least they are taking care of some aspect of health of older persons. But if we just give up that specialization and just broadly consider all physicians who are seeing older persons on a day-to-day basis are considered as a geriatric workforce, we may be overestimating the available resources who may be ready to provide a quality care. I think the question is to what extent this other professionals like cardiologists, ophthalmologists can provide a quality care for older person is a key question. So we don't have a straightforward answer to this, but this is an important area where we want to work with the IAGG working group to think through very carefully. Thanks.
Maybe just to clarify, I think maybe we should differentiate between whether someone is part of the geriatric workforce or contributes to it. And maybe that's a slight difference between how you define the geriatric workforce and how people contribute to the work of the geriatric workforce.
I think that might be a useful functional approach. On the other hand, I think we have to be very careful that we don't develop a system in which some clinicians taking care of older persons get the impression that they're seen as second-class citizens, that they are not fully valued, and so that whatever nomenclature we develop or definitions we develop, we want to make sure that these roles are attractive roles to people, because we need to grow this workforce.
I have another question. If you want to answer, please. It's from Dr. Shapira Moises. He wants to know if isn't the definition of geriatrician you offer to the WHO very light and inspecific, and it does not include entrustable capacities such as family, meeting management, and the core of the model.
Well, I think that we are including those features, maybe not those specific words, but I think we are including those features in the definition. As we iterate it, you know, we have this 1 or 2 sentence definition, but when we describe the characteristics of the practice of geriatric medicine, or certainly our intent is to include those features.
Anybody want to answer the question too? Okay, if there are no more questions, you want to make a conclusion of this meeting, and please, I listen to you last minute to make the close of this symposium.
Well, I would just like to commend the World Health Organization. IAGG is delighted to be a partner with them, but I think that they're stepping up to the plate and embracing this issue has the potential to have a very significant beneficial effect. Many of us in the field have been working more or less in isolation. We have tried to IAGG and other organizations to coordinate activities, but the involvement of the World Health Organization is a very welcome event.
Anshu, you want to make a...
Thank you, Miguel. And I think this is a new area of work for us. So we're very excited about, you know, how to take this forward, and we can learn a lot from other work that has already been done around the health workforce. So we're first of all very excited to work with the IAGG to define the different cadres that we think fit within the geriatric workforce, and that definition should help us. Secondly, what would be important is to be able to collect data on the health workforce, being able to deliver care for all the people according to the competencies that are needed, and then use that data to project the potential demand for the health workforce needed to care for older people, and particularly also looking at you know, the fact that the population is aging, and would of course like to call on anyone who would be willing to or be interested to participate in this endeavor to join us. So, but I think this is a new area of work that we need to get more clarity on, and we'll be very happy to collaborate with others to take this forward.
Okay, Matteo, you want to say something?
Yes, it was just to really solicit every geriatrician, every member of the geriatric workforce, really be courageous, but trying to profit of the expertise that has been gained over years. Because I mean, modern medicine is facing problems that geriatricians have been dealing with for decades. So we have on our sides a lot of experience that we have to put forward, giving visibility to our discipline. And I think also trying to go at a higher level, besides of the clinical relationship with the patient, also trying to influence policies and the orientation of services.
Okay, Jotheeswar, we have half minute to conclude.
Yes, I'll be quick, Miguel. I think from WHO side, I would like to really thank you and Jack and Matteo and all the members of the IAGG WHO working group on geriatric workforce for really coming forward to help us to come up with the definition, and also agreeing to work with us to expand the scope of the work to other cadres that we want to classify, and we wanted to find them for data collection. So I'm really grateful for this support, and we are very happy to collaborate with you and continue to work with you. Thank you.
Okay. Thank you for all the speakers, and it was a pleasure and an honor for me to chair this meeting. Thank you very much to the EIGG and the WHO. Thank you very much. Bye-bye.